This is Dr. Raj Chandwaney. I'm making this presentation for our STEMI outreach program at Oklahoma Heart Institute. This is a presentation which I would normally give in person to our outreach hospitals, but because of COVID-19, we've not been able to make those presentations. Just get my laser pointer up here. So just a little bit of background information to grab your attention. Cardiovascular disease is still the #1 killer in the United States. It accounts for 1 of every 3 deaths that occurs in our country. The majority of these coronary artery disease deaths are due to coronary artery disease, which accounts for almost 50% of the total death rate. Each year, an estimated 785,000 Americans will have a new heart attack. 470,000 Americans will have a recurrent heart attack. What that translates out to is that every 25 seconds, an American is dying of a coronary event, and every minute, someone is dying from one. How are things locally? Horrible. The state of Oklahoma consistently ranks as having the worst coronary artery disease death rate in the country. Whenever I give a presentation about STEMI, I think back to one of my favorite teachers back in medical school. He would always say, when I ask you a question on rounds, I would like to get 5 answers. If you give me 1 or 2, I'll think you're dumb. If you give me more than 5, I'm not going to remember anything you say. So I try to adhere to this rule whenever I give a presentation. I'm going to do my best to not underwhelm you and not overwhelm you. So there's 5 questions I hope to answer with this presentation. First, what is STEMI? Second, how is STEMI diagnosed? Third, how do we treat STEMI? 4, what is Mission Lifeline? And 5, what is the OHI STEMI transfer protocol? What is STEMI? STEMI occurs when a coronary plaque ruptures, and because of the plaque rupture, platelets will aggregate on top of the ruptured plaque and form a thrombus. If that thrombus grows and only partially obstructs flow through the artery, this would lead to either unstable angina or a non-ST elevation myocardial infarction. On the other hand, if that thrombus grows and obstructs flow through the entire artery, and this is a major artery that feeds the heart, this will lead to ST elevation myocardial infarction. If that ruptured plaque were to occur in a vessel here as the left anterior descending coronary artery and obstructs flow through the entire artery, the heart muscle that's normally perfused by that portion of the artery will be at risk. As time goes by, the amount of myocardium which will turn necrotic or into scar tissue will expand. If 24 hours go by without establishing reperfusion, the entire territory of myocardium will turn necrotic and be irreparably damaged. So during a STEMI, we have an unstable plaque which ruptures. This can lead to coronary occlusion, and then basically 3 things can happen. Some patients will die within the first 24 to 48 hours of their STEMI if they're not treated with reperfusion. Other patients will survive. However, if they do survive, they're left with a weakened heart because part of their heart muscle is now scar tissue. Those patients will suffer with chronic congestive heart failure, and unfortunately those patients do have shorter lifespans despite all the modern therapies that we can offer these patients. The other thing that will happen is the heart will remodel. What that means is because of Laplace's law, the heart is trying to maintain adequate wall tension, so it'll stretch and dilate. That'll stretch and dilate the heart's electrical conduction system, and this will lead to ventricular arrhythmias. Patients in this situation would be treated with antiarrhythmic drugs, defibrillator, and despite those therapies that can reduce the occurrence of these arrhythmias, patients in that situation will still have a shorter lifespan than patients who never had a STEMI. So our goal in developing an aggressive outreach STEMI program is to establish reperfusion early to prevent any of these three possible outcomes. This is an autopsy specimen of a heart in a patient who had a STEMI. As one can see, if you look at between 12 o'clock and 3 o'clock, this heart muscle is scar tissue. And this is what we're trying to prevent with an aggressive STEMI program. We're trying to prevent the patient from developing a lot of scar tissue in their heart. More importantly, we're trying to prevent that patient's heart from becoming an autopsy specimen in a pathology lab. So what are the symptoms of STEMI? Patients can present with chest pain. It's classically described as a pressure or tightness. It'll usually radiate to the neck, jaw, arm, or to the back. It can be associated with shortness of breath, nausea, a cold sweat, or lightheadedness. I want to emphasize the American Heart Association, when they list the symptoms of STEMI, will not say and. It is and/or. What I mean by this is patients don't necessarily have to present with all of these symptoms when they're having a STEMI. There are certain patient groups which we know will have atypical presentations in the setting of a STEMI. Women in general, for example, will often describe their chest pain in atypical manners, sharp, tingling. They'll use terms that doctors do not usually use to categorize cardiac chest pain. Other groups of patients, such as diabetics and the elderly, may never have chest pain in the setting of a STEMI. Their only symptoms might be some breathlessness, nausea, cold sweat, lightheadedness. Especially when we're talking about a diabetic population, this can be very challenging because the common symptoms that are associated with hypoglycemia can also be the symptoms of a STEMI. So we really need to be on the lookout for STEMI symptoms in that high-risk population. How do we diagnose STEMI? It's with an EKG. The American Heart Association recommends that patients who present with STEMI symptoms should have an EKG within 10 minutes of presentation. What we're looking for on the EKG is significant ST elevation. This EKG is showing marked ST elevation in V2, V3, and V4. To diagnose STEMI, the typical criteria required: in a male, you would require 2 millimeters of ST elevation in 2 contiguous leads in the precordial leads, or 1 millimeter of ST elevation in 2 contiguous leads in the limb leads. If it's a woman, the limb lead criteria are the same. However, the precordial lead criteria are 1.5 millimeters. I should mention, looking at this EKG, it's clear that this patient has closed their left anterior descending coronary artery. The very astute observer would notice that there's also ST elevation in 1 in ABL, which is the high lateral leads. This would suggest that this patient has not only closed their left anterior descending coronary artery, they've done it in the most proximal segment before the first major diagonal artery. So this patient's having a massive ST elevation, myocardial infarction, and their life is clearly in danger. How do we treat STEMI? Before the 1980s, we didn't have great ways to treat ST elevation myocardial infarction. Back in those days, patients would be admitted to the hospital, they'll be monitored, their symptoms would be treated with morphine, and we really just hope for the best. Luckily, in the 1980s, thrombolytics were invented. These are medications which can dissolve clot. So you can imagine if we could just dissolve that clot, which has formed on top of the ruptured plaque and is obstructing flow through the artery, we can reestablish flow in the artery and abort the patient's STEMI. So thrombolytics were a huge breakthrough in medicine when they were developed in the 1980s. This slide summarizes a meta-analysis of multiple studies which proved the benefits of thrombolytic therapy in patients with ST elevation myocardial infarction. An important retrospective observation that was made in the thrombolytic trials was that timing of treatment was actually very important. We didn't know this before those trials were conducted, although it had been hypothesized by many experts. Here you can see that if we examine the time from onset of symptoms to treatment, the more time that goes by since the onset of symptoms to when the patient reestablishes flow in the artery with thrombolytic therapy, the poorer the outcomes are. So this is when we started to discover that time matters in patients with ST elevation myocardial infarction. Although thrombolytics were a huge breakthrough, they're far from perfect. Unfortunately, one problem is they don't work all the time. Most studies would show that thrombolytics would reestablish brisk flow in the artery in only 50 to 60% of patients who were treated with thrombolytics. Another huge problem is the contraindications that providers need to be concerned about before administering thrombolytic therapy. The absolute contraindications would include any prior intracranial hemorrhage, known cerebrovascular lesions such as an arteriovenous malformation, known malignant intracranial neoplasms, ischemic stroke within 3 months, unless of course it's a stroke within the last 3 hours, because that's an indication to treat the patient with thrombolytics for stroke. Suspected aortic dissection. This is challenging because this type of clinical presentation would always include aortic dissection in the differential diagnosis. Active bleeding or bleeding diathesis other than menses, and significant closed hand injury or facial trauma within the last 3 months. In addition to this list of absolute contraindications, there's an even longer list of relative contraindications that ER physicians had to worry about before administering thrombolytic therapy. Because of all these concerns, even after thrombolytic therapy was proven to work and there were guidelines published recommending that this be administered in emergency rooms to treat patients, the truth was they were tremendously underutilized because of ER physicians' concerns about giving the medicines to the wrong patient. Luckily, things have improved. Now, the state-of-the-art treatment for ST elevation myocardial infarction would involve an emergent cardiac catheterization with percutaneous coronary intervention. This is a coronary angiogram of a patient who is having a large ST elevation myocardial infarction involving the anterior segments of the left ventricle. The expert eye can quickly look at this angiogram and note that there's something missing. This is the left anterior descending coronary artery here, and the vessel should continue to travel down in this direction, but the vessel is missing. This is a large diagonal branch artery right adjacent to that obstructed artery. So in the cath lab, we would efficiently advance a guide wire across the blocked artery. That guide wire will act as a railroad track for us to deliver balloons and stents in and out of the artery. These two dots here on the wire represent a balloon catheter, which was advanced across the area of the obstruction. That balloon catheter would be inflated. Stents would be deployed in the artery. And here you see the left anterior descending coronary artery with reestablished flow that was missing from that first picture. Why is emergent angioplasty and stenting the state-of-the-art treatment for STEMI? Because it's better. Here's a summary of randomized trials comparing emergent angioplasty versus thrombolysis for the treatment of STEMI patients. You can see that angioplasty is much better than thrombolytic therapy in all of the hard endpoints examined in this slide. Importantly, thrombolytic therapy does carry a 1% risk of hemorrhagic stroke to any patient who receives it. With emergent angioplasty, that risk is negligible. Here you see 0.05%. I should point out this bar is drawn incorrectly. It's drawn as 0.5%, but this bar should actually be much lower than that at 0.05%. The improvements in treatment are not just seen in the first month after treatment, but those improvements are durable. This slide shows even 6 months post-treatment, emergent angioplasty is better than thrombolytics at treating patients with ST elevation, myocardial infarction, when you look at the endpoint of mortality. Again, retrospective analyses revealed that timing is important when treating STEMI patients. In this slide, you can see the 1-year mortality rates in patients treated with emergent angioplasty. As time goes on, between the onset of symptoms to that first balloon inflation, the outcomes get worse. And this is where we started to establish the phrase that with STEMI patients, every minute counts. Because as time goes by, the amount of dead myocardium will increase. The amount of myocardium that can be salvaged with the angioplasty procedure will decrease. Based on these observations, the American Heart Association, the American College of Cardiology established these treatment goals for STEMI patients approximately 20 years ago. If you're going to treat a patient with thrombolytic therapy, you want to establish a door to needle time of less than 30 minutes. What that means is from when the patient arrives to your emergency room to when the thrombolytics are being started in the IV should be less than 30 minutes. On the other hand, if your hospital is treating the patient with emergent angioplasty, you want to establish a door to balloon time less than 90 minutes. From when they arrive to the door to when that balloon is being inflated in the artery, again, should be less than 90 minutes. Why is there a difference between these goals? Well, usually thrombolytics take about an hour to work, and essentially we're shooting for about 90 minutes from when we reestablish flow in the artery. This study came out about 18 years ago, a couple years after those initial goals were established. And what it showed is that at that time frame, hospitals were not doing a good job of providing patients with timely STEMI care. As you can see here in high volume hospitals, which are the red bars and the highest performing quartile, the median door to balloon time was 96.5 minutes. Because of those observations, the cardiology community formed professional societies to try and improve the outcomes here. The Door to Balloon Alliance was an early quality initiative that was started, as was the Action Registry, which was part of Get With the Guidelines in those early years. And by doing this, we were trying to shorten the amount of time that patients would be experiencing the STEMI before they receive treatment. If you think about this, there's actually multiple areas that needed to be worked on. The different colored parts of these bars demonstrate different parts of the time delays that needed to be addressed. For example, the yellow bars represent time delays that are created by the patients themselves. Many patients will endure their symptoms at home far too long before they seek medical attention. And this needs to be tackled with media campaigns through professional societies such as the American Heart Association and other patient education campaigns that can be made publicly. The American Heart Association recommends that patients who are having symptoms of a STEMI, if those symptoms last more than 5 minutes, should call 911 and take 4 baby aspirins at home if they're available. Most patients are enduring their symptoms for several hours before they seek medical attention. The purple bars represent delays that occur with transportation. Again, we want to encourage patients to use 911. We don't want them to drive themselves to the emergency room. That creates time delays because they're driving through traffic. It can lead to car accidents if patients go into a cardiac arrest because of their STEMI. And so we really want people to use 911. And we also want paramedics to have protocols in place for timely transportation with STEMI patients. Another thing that we're doing in Tulsa for well over a decade now is our ambulances are equipped to obtain a pre-hospital EKG. So our paramedics will actually obtain that first EKG in the field, if they identify STEMI, they're going to move a lot faster than otherwise. They're also going to transmit that EKG to the receiving hospital, so the hospitals can prepare for the STEMI patient before the patient even arrives, with knowledge that there's a STEMI headed their way. The blue bars represent delays that can occur within an emergency room. So we want hospitals to have protocols to timely assess patients with STEMI or STEMI equivalent symptoms, whether it's getting that first EKG, if it's a walk-in patient, or if it's a patient that we know is having a STEMI because the EKG has been transmitted by paramedics. We have protocols in place to deal with these STEMI patients. You do not want to reinvent the wheel every time a STEMI patient comes to your emergency room. And whether that pathway involves thrombolytics or whether it involves emergent angioplasty, everyone should know what the game plan is. In addition to that, we should have quality improvement programs in place which are monitoring the time frames that these patients are receiving treatment, so we can learn from our mistakes and do a better job with the next STEMI patient. The pink bars here represent the delays in treatment itself. If your hospital is using thrombolytics as its primary reperfusion strategy, you shouldn't have to make a phone call to the pharmacy to mix up the thrombolytics every time you need it. It should be in your Pyxis in the ER, ready to go, so it can be quickly hung and administered to the patient within that 30-minute goal. If you're performing an emergency angioplasty, the cath lab itself should have protocols in place for getting these patients up to the cath lab in a timely manner. And once these patients are on the table, protocols in place to quickly get that artery open. So this is a slide just showing you how we've been performing at Oklahoma Heart Institute. This slide goes back to 2005. Over the years, we've consistently maintained door-to-balloon times well below that 90-minute goal. And really over the last 7 to 8 years, we've been well below the 60-minute target of getting this artery open quickly and promptly. In 2019, our time was 57 minutes as well. So what is Mission Lifeline? Mission Lifeline is an initiative that was set up by the American Heart Association to try and improve STEMI care throughout the communities. This was not just in communities in big cities that have large cath lab hospitals, but also in rural communities. People live in communities where the hospitals do not have a cath lab. And we want to get these patients to the right place, treated promptly and safely. And Mission Lifeline is focusing a lot of energy on these efforts. So one of the first questions that we needed to answer at the American Heart Association's Mission Lifeline program is, what is the best way to treat a patient who presents to an outlying community hospital in a small town that does not have a cath lab? One option would be to treat those patients with thrombolytics within 30 minutes, and then send them over to a tertiary receiving hospital that has a cath lab for cardiac catheterization later on if needed? Or do we just skip the thrombolytics and get those patients transported as quickly as possible to that tertiary receiving hospital for an emergent angioplasty or stenting? You have to remember that thrombolytic therapy does carry a 1% risk of intracranial hemorrhage. And if we can eliminate that risk, there's tremendous benefits for the patients. So what these studies showed is that when randomizing patients who present to these small rural outreach hospitals, angioplasty is actually superior to thrombolytics, despite pretty large time delays that were created by sending them to the second hospital. Now, when these studies first came out, they proved that the rates of death, reinfarction, and stroke were lower with angioplasty compared to thrombolytics. There were some criticisms regarding the U.S. potential to achieve these good outcomes. The majority of these trials were performed in Europe, except for AIR-PAMI, which was performed in Michigan. And in Michigan, although there was a trend towards improvement in outcomes, it was not statistically significant. And part of the problem here is that they had the greatest time delays to treatment. The other ones were well below 120 minutes, but in AIR-PAMI, you were hitting a 155-minute delay in treatment by sending the patient to a second hospital. At some of our international professional meetings in cardiology, there were some critics saying, you can't do this in the United States. Your healthcare system is a little bit too messed up. It's very heterogeneous. You have all these different hospital systems owned by different players competing with each other, and you're never going to make this work. However, Dr. Timothy Henry, who at that time was leading the efforts at the Minneapolis Heart Institute, published this study. Basically, if you read their conclusions, rapid transfer of STEMI patients from community hospitals up to 210 miles away from a PCI center is safe and feasible using standardized protocols with an integrated transfer system. Essentially, if you make a plan, we can do a good job of this in the United States just like they can in Europe. So back in 2011, we established our STEMI outreach protocols, where we started telling outreach hospitals, skip the thrombolytics, just get the patient to Oklahoma Heart Institute as fast as you can, and we're going to take them straight to the cath lab. Now back then, when we first started the program, there were not any goals set by our professional societies as to what would be the right treatment goal as far as time duration to strive for if you're going to do a STEMI outreach program. Based on our analysis of the medical literature, we arbitrarily set our goal at 120 minutes. Our plan was to try and get these patients to the cath lab and opening their artery 120 minutes within the time that they arrived at the outreach hospital. And these are our data over the past few years. When we first started this, we were above that 120-minute goal, but over the years we've been able to chip away at this time. And in 2019, we were down to 98 minutes, outreach door time to our balloon time on these patients who are presenting to outreach hospitals with ST elevation, myocardial infarction. Interestingly, that 120-minute goal has been now documented to be the stated goal by all of our professional societies for treating outreach STEMI patients. When a patient arrives to an outreach hospital, we want to get them transferred, and we want that artery opened at the second hospital within 120 minutes. This was a case series that was presented by a group out in Pennsylvania, and they were some of the early adopters of a STEMI outreach program. And I do think their title overstates their achievement slightly, where they say that door-to-balloon times under 90 minutes can be routinely achieved for patients transferred with ST elevation myocardial infarction. If you look at their data more closely, this was their data from 2004 to 2008. 2008 was their best year. Their door-to-balloon time of less than 90 minutes, although in the majority of patients it was at 53%, which it's hard for me to call that routine. Nevertheless, these are impressive numbers. They did achieve a door-to-balloon time less than 120 minutes in 83% of patients. Like I said, these were people who were ahead of the curve in making efforts towards this outcome, and they really did a tremendous job here. What was really nice about this paper when it was first published is it wasn't just published to brag their great outcomes. They did a great job in the text of their article telling us what exactly they did to improve those numbers from 2004 to 2008. And what they really focused on was feedback. Giving hospitals and the outreach community feedback regarding their performance. And I want to emphasize that when you give hospitals feedback, this is not to slap them on the wrist when things didn't work out perfectly. It's to just give them the information and let the outreach hospital solve their problems. I think every outreach hospital has a different set of obstacles that they need to overcome. There are things that sometimes we can share with the outreach hospitals, lessons that we've learned from other outreach hospitals as to how to improve things. But outreach is clearly dependent on getting this feedback to improve outcomes. So normally when I give this presentation in person to one particular hospital, at this point I would put this slide up, which will show the outreach hospitals individual data as to how they've done over the past several months or the past year or so. And what we're looking at on these STEMI outreach patients is several parameters. We have a door to EKG goal. We want the outreach hospital to obtain an EKG on the patient within 10 minutes of arrival. And then we have a door to system activation is really what this should say. In the past, we would interpret system activation to mean when you called Oklahoma Heart Institute that you were going to be sending us a STEMI patient. Nowadays, we're doing this as an either or. The time that we're checking here is either when did you call OHI or when did you activate the ambulance system. Whichever one occurred first, we interpret as the activation time for activating the protocol. Door in, door out time. We're keeping track of how much time does it take from when that patient arrives to an outreach hospital to when they leave. That goal that we've set is an aggressive goal for 30 minutes. We did this on our own, but there's actually been some literature that suggests that 30 minutes is the right time to strive for, even though it's a difficult obstacle for many hospitals to consistently overcome. I think this is the correct door in, door out time for us to be striving for. Transport time, we're giving the EMS services 45 minutes from when they leave the hospital to when they arrive at our hospital with the patient to get here. And then from when a patient arrives here to when we're inflating a balloon in the artery should be less than 30 minutes. Most of these patients, because we can prepare in advance, are actually brought directly to the cath lab and placed on the cath table as they come off of the stretcher. And then we're giving ourselves 30 minutes to get that artery open. So our overall goal on the STEMI outreach patients is the door to balloon time of less than 120 minutes. Since today we're doing this on tape, I don't have your hospital's individual data. However, Tamara will be providing you with that data, and I encourage you to look at that closely, see what we can do differently to improve our care for the next patient. This is the slide which summarizes why a door in, door out time of 30 minutes is probably the right goal to be striving for. This was a paper that was published in JAMA. If you look at the conclusion, a door in, door out time of 30 minutes or less was observed in only a small proportion of patients transferred for primary PCI, but it was associated with shorter reperfusion delays and, most importantly, lower mortality rates. So really on these STEMI outreach patients, one of the most important things you can do in taking care of these patients is to get them out of your hospital as soon as possible. Get them on that ambulance, get them headed in our direction, and that's the most important thing we can do to improve this patient's chance of survival within your emergency room. So what is the OHI STEMI transfer protocol? We definitely want an EKG to confirm STEMI. You can activate the system, and on our end we'll be eventually asking for that EKG, making sure we get a chance to see it and we agree with STEMI, but we want the ball rolling even before we make that confirmation. The other reason it's very helpful for us in the cath lab to see that EKG is we can plan our procedure appropriately by determining what our target vessel is likely to be. As far as medications, we don't want to give this patient too many medications. We don't want to slow things down. So basically all we're asking is that we give 325 of aspirin. We want to load them with either 600 milligrams of clopidogrel, or if your emergency room has Brilinta, we'll use 180 milligrams of Brilinta. We want to give that patient a heparin bolus of 5,000 units. We don't necessarily need to start a heparin drip. What we're finding is that starting drips leads to delays in getting that patient out of that ER. Just give them the bolus. The bolus should keep them covered for the transportation time. And we're going to check their ACT heparin levels upon arrival in the cath lab, and we'll give additional heparin if we need to once they arrive here. Hanging too many drips usually just leads to more delays. You want to notify your transportation service of choice as soon as possible that you have a STEMI patient that requires rapid transport. What we're hearing from a lot of the transportation companies, if they know it is a STEMI patient, they perform at a different level than they do otherwise. So if it's a STEMI patient and you're calling that ambulance service or that helicopter transport service, if you have a STEMI, be sure and tell them it's a STEMI because it lets them perform at a different level. This is the phone number that we want you to call at OHI to activate our STEMI protocol. Like I said, the nurses there will be asking you for some information on the patient. They'll be asking you for an EKG. You may eventually get a phone call from the receiving cardiologist to get some more information on the patient. I personally always like to do that. It saves me time when the patient arrives if I can just get the historical information from you. And we're going to get that ball rolling. Even if you're getting all these phone calls from us on our end, we're trying to secure a cath lab for this patient. If it's after hours, we're bringing in a team from home. A lot of things are happening behind the scenes once you make that first phone call. On our end, Oklahoma Heart Institute has an auto accept policy for all STEMI patients. Obviously, please don't abuse this for patients who are not STEMI patients. But even if you called our hospital about 10 minutes earlier for a pneumonia patient and you were told that there was no hospital beds available, if you have a STEMI patient, we recognize that these are patients who have a very high risk of death. If they're not treated in a timely manner, we will accept that patient. On the back end, we might have a nurse sitting with this patient in a holding bay until an actual hospital bed becomes available because we're full. But on the front end, we're going to accept this patient and get him treated. As I mentioned, you may get a phone call from the cardiologist just getting some more information, wanting to see the EKG. On our end, we're activating the cath lab prior to arrival, trying to get everything situated to open this patient's artery as quickly as possible. One thing I wanted to mention, I know lots of times when we make these presentations in outreach hospitals, we'll also invite some of the local paramedics from the EMS services. And I just want local EMS services to be aware that OHI also has a STEMI bypass protocol. What this means is that we are suggesting to rural ambulances that if you have the technology to obtain a 12-lead EKG in your ambulance and you confirm that it's a STEMI and you can transmit that EKG, you do not have to take this patient to your local emergency room. You can actually bring the patient directly to Oklahoma Heart Institute to prevent any treatment delays that might occur for this patient at the outreach hospital. If possible, it would be ideal if the ambulances can be equipped to administer aspirin, clopidogrel, and maybe a heparin bolus. That would be wonderful, because if you can achieve those 3 medications, you are actually medically treating your STEMI patient the same as they would be treated if you took them to that small rural outreach hospital that does not have a cath lab. So if you're in that situation, again, I think the most important thing for these STEMI patients is the time that it takes to open the artery. And if you could just bypass that outreach ER and get the patient to us as quickly as possible, that would probably be the best thing for the patient. I know that there are certain issues in some of the small towns that do not make this feasible. Some small towns only have 1 or 2 ambulances, and if they drive all the way to Tulsa, then there's a pretty long period of time that there's no ambulance available in that community. But I think this can be individualized, and I leave it to each community to make their own decisions regarding whether or not they're going to use the OHI STEMI bypass protocol. I just want you all to know that it is something that is available and that we would accept patients for. Thank you for your attention.